Hello, my name is Dr. Christopher Blackwell. I'm an associate professor, acute care nurse practitioner, and program director for the adult gerontology acute care nurse practitioner programs in the Department of Nursing Practice in the College of Nursing at the University of Central Florida. I'd like to welcome you to the second part of a five-part narrated PowerPoint series covering Unit 2, Neurologic and Neuromuscular Healthcare Problems for the NGR 6212 Adult Gerontology ACNP 3 course. This is the second part of a monstrous unit covering a ton of material, and in this particular lecture we are going to be discussing neurological care in the ICU. And I'd like to give a thank you to Dr. Rosalind Reichman, who is a retired acute care nurse practitioner and faculty member from the University of Florida College of Nursing, who provided content for the lecture. Okay, so we already learned in the first unit of the course, and by the way, there's going to be a lot of overlap with some of the first unit of the course and the material we're going to cover today because, well, traumatic brain injury is a huge part of neurologic ICU monitoring and assessment and care, so that's going to come into play here. But remember that we learned in the first unit lecture that the secondary brain injury is that of which is associated with biochemical, cellular, and molecular mechanisms. And we learned specifically that these processes were mediated essentially by calcium reactions that occur within the cells. And we're going to take a look at that in just a few minutes with a little bit more detail. Okay, so evolution of secondary damage after ischemia or TBI. So ischemia, excitotoxicity, energy failure, and ultimately cell death cascades. You get cerebral edema and axonal injury. Inflammation and regeneration influences each of these three cascades, so that ischemia, excitotoxicity, energy failure, and cell death cascade. And brain edema and vascular injury, not major therapeutic targets after a global cerebral ischemia. Okay, so we'll talk a little bit more about what that means in just a few minutes as we progress here. But basically, we know that the brain sustains the direct trauma or the direct injury from ischemia or stroke, for example, or ischemic event from either a thrombus or an embolism or a bleeding out event like a hemorrhagic stroke. And then we get these secondary effects which cause even further damage to the neuronal tissue. Cardiopulmonary arrest, model of global cerebral ischemia, resuscitation if brief, being within 5 to 12 minutes. The ATP will deplete in less than 2 minutes in the brain, and you can get membrane failure as a result, with a loss of ion homeostasis and a release of potassium with uptake of calcium, sodium, and chloride. So again, we're going to talk about why this plays a major role in some of the schematics I'm going to show you in just a few minutes. Reperfusion consequence depends on duration, so you can have transient hyperemia, which lasts just minutes, followed by delayed hypoperfusion, which can last for hours. And there are neuroprotectant responses which get initiated, increased intracellular calcium, which we talked about playing a critical role, and then the pattern of damage after global cerebral ischemia, also known as selective vulnerability. And we'll talk about what some of these patterns of damage are as we progress. So this is the various or different categories of biochemical, cellular, and molecular mechanisms proposed to be involved in the evolution of secondary brain damage. So you can see here, let me get my pointer out. So obviously, injury occurs, right, which is that first initial primary injury, direct parenchymal and vascular disruption, right, and depolarization, and then it follows different pathways here. So if it's ischemia, then these things start to occur, okay, ultimately necrosis, right, and then if it's injury, so go back to the injury, contusion will result in formation of hematoma. Astrocyte swelling can occur with ischemia or contusion, and then that ultimately leads to increased ICP. And you can see that increased ICP here as a consequence of all of these pathways here, which involved increased tissue osmolar load, vascular dysregulation, increased blood-brain barrier permeability, all these things that result in cerebral edema, inflammation, and in some cases collection of blood and other foreign agents. Well, I guess foreign agents is not really the right term to use, but agents, let's just say, that the closed cranial vault has difficulty containing, that normally aren't there. Okay, so we don't normally have collections of blood, for example, in the brain. We don't normally have collections of coagulated blood from a hemorrhagic event, or we don't have tumors normally, right? So those are all things that that can increase ICP and lead to significant problems. Focal cerebral ischemia, a thrombotic or embolic event, is what causes this. It produces a dense ischemic focus surrounded by peri-ischemic penumbral region with intermediate CBF. And the ischemic focus is unsalvageable unless we can get it reperfused immediately. So this would be somebody that would come in with very early onset of symptoms, and we can get TPA on board immediately and get them reperfused. Then that would be an example of where this would come into play. The penumbra with some collateral flow is a therapeutic target for reperfusion with thrombolytics and or pharmacologic therapy as well. Pannecrosis of vasculature and astrocytes, of course, results in infarction, and the astrocytes are unbelievably important, and you can see pictures of these astrocytes here in this slide. Okay, and the astrocytes, the reason why they're so important is because they provide a lot of support, and when I mean support, I mean biochemical support to the brain tissue itself. Okay, they're involved in a lot of metabolic processes, they're involved in nutrition, they're involved in some of the cleaning, if you will, of dead cells and other things within the brain. They are very, very important components of the brain. And unfortunately, when you get this pan-necrosis and these astrocytes die, you get infarction, so cerebral infarction. Classic apoptosis, which is, remember, apoptosis from your patho days is the term that we use for programmed cell death. We don't see that classic process, and I'll show you what that classic process looks like in just a second. But astrocyte swelling and blood-brain barrier injury do play an important role in the ischemic process, and if there's a large focal damage, you can get an increase in ICP. And you probably think, well, why is that, Dr. Blackwell? Well, it's because when you get that significant focal damage and that tissue dies, it can set off an inflammatory reaction that can cause significant cerebral edema, and that will ultimately lead to rises in ICP. Remember that the normal ICP is between 0 to 15 millimeters of mercury, and once we start getting above that, we start worrying about, obviously neurologic symptoms, but herniation as a major consequence. We'll talk more about herniation. We've already talked a little bit about herniation. Focal cerebral ischemia from delayed vasospasm is the most common critical complication from a subarachnoid hemorrhage. Okay, so this is a really good explanation here of how a bleeding event, right, so subarachnoid hemorrhage, can end up leading to severe focal cerebral ischemia. And that's because these patients will get a delayed vasospasm. And that vasospasm obviously cuts off flow to the brain tissue, resulting in ischemia, resulting in necrosis, right? So that's an unbelievably terrible consequence of SAH that usually it can be a leading cause of death, and certainly cerebral ischemia. With traumatic brain injury, there are biochemical and molecular mechanisms that can occur, and these oftentimes depend on the type of injury that we're talking about. So, for example, in a focal contusion, you get a direct disruption of the parenchyma or parenchyma with local necrosis and hemorrhage, resulting in superimposed vascular disruption, blood-brain barrier permeability, and localized ischemia. And unfortunately, when those things occur in concert of one another, it sets the stage for excitotoxicity and necrotizing cascades. And again, like we said before, these tend to occur in the penumbra, and you get this local axonal injury that results as a consequence. And complicated, commonly, if you have a complicated injury, commonly you see local swelling and increased ICP with the potential for a secondary focal or global ischemic event, or of course at that point we're also talking about such significant edema and direct primary damage to the tissue that they can herniate. Secondary extracerebral insults include things like hypotension, hypoxemia, and of course these complicate responses and we know will play a negative outcome. Will can help play a role in a negative outcome. So unbelievably important for us in the ICU environment when we're dealing with somebody who has a traumatic brain injury, or really any brain injury for that matter, that we're avoiding these things, right? And these are just two examples. We could throw hyperglycemia in there. We could throw hypoglycemia in there. Those are also going to be secondary insults that we want to avoid in the ICU. We want to make sure that tissue does not heal inappropriately, or even worse, that we're not causing the patient to get to get worse because of what we're doing or what we're not doing. Okay, so excitotoxicity, this is the process by which glutamate and other excitatory amino acids cause neuronal damage. And we know that glutamate is most abundant in the brain. It's the most abundant neurotransmitter. Unfortunately, though, even though it plays a vital role in neuroconduction, it can reach toxic levels. So when the cells die and this glutamate gets excreted as a consequence, it can become toxic. Processes and receptors lead to opening gates in membrane, allowing increased intracellular calcium. And we learned again that calcium is a major culprit in terms of long-term cellular death in the brain, right? We know that, and that's one of the processes that's very important. Hang on one second, my little schnauzer wants to come up and sit on my lap. Okay, there we go. Okay, so an example of increased nitric oxide production leading to DNA damage. No, do that. PARP, okay, so PARP, what is PARP? This is an enzyme which is normally operative in DNA repair, and it is present in the brain, and it is a good thing. But unfortunately, when you get traumatic brain injury or other types of insults, it becomes overactivated, and over time that overactivation can deplete both NAD and ATP. And so what happens as a consequence is you get this metabolic failure within the cell, and then ultimately that apoptosis or cellular death. And here is a little figure of excitatory mechanisms that are involved in this process. So proteases, lipases, endonucleases, NNOS activation, O2 radical formation, perioxynitrate formation, mitochondrial damage, DNA injury, and then ultimately cell death. And like you've heard me say a million times, look here, guys. Calcium, 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 calcium. Lots of calcium, right? So we see that this leakage of calcium from these excitatory mechanisms really is what causes this toxicity. It's really a very ominous culprit within this cascade. So programmed cell death cascades is a continuum from necrosis to complete apoptosis, new phenotypes, autophagic degeneration, programmed necrosis, and parthenosis. Apoptosis is, like I said, that description of cell death. It's cell shrinkage and nuclear condensation with internucleosomal DNA fragmentation and formation of these apoptotic bodies. And it requires a cascade of intracellular events which are all programmed. And necrosis, cellular and nuclear swelling with dissolution of the membrane. So looking at the actual cellular level of what necrosis or what is happening that causes necrosis is essentially that cellular and nucleus component of the cell being so edematous that it just basically it lyses, it breaks the membrane and kills the cell. Apoptosis, again, evolutionary conserved process for selective cell elimination during development, but it does obviously occur in all tissues. Otherwise, we would live forever. Requires novel gene expression and protein synthesis. It's critical for cell turnover and renewal, and we call this molecular debridement. So think about when you're debriding a wound and you're scraping off the old nasty necrotic tissue on top of the wound so that you can get to granulation tissue that can actually heal the wound. Well, that's what's happening here with apoptosis. We're getting rid of the dead cells and we're debriding essentially all areas of the body, not just the brain, although that's what we're talking about tonight or today. Cybernetic and may occur via multiple pathways that possibly are independent, and crosswalk can occur. And neuronal apoptosis has two pathways. There's the first, which is activation of the family cysteine proteases or caspases, and then there's the caspase independent pathway. So that's how cell death occurs in neuronal tissue via those two pathways. So this is initiation or regulation of neuronal programmed cell death after injury. And on your exam, I'm just going to give you this blank model here, and you're going to have to actually just fill in all of these on your own, right? No, I would never do that to you, but I'll tell you something. I had an undergrad anatomy professor that used to do that. Seriously, he would give us exams where we would have like the skeleton, and he would like expect us to fill in every single bone. It was insane. But yours truly made an A. I can't believe I did, but I did. I was a nerd. But anyway, you can take a look at this. It just kind of complements some of the things that we've already said in terms of how these cells are programmed to die. And then this is just the execution of neuronal programmed cell death, so it's similar to that process, except this is after injury, and this is, I believe, just normal cell death. I would never test you on this process, but it's just something that you need to know because a lot of the therapies that we use target some of these pathways, and so it's good to know why we're doing what we're doing. Cerebral edema can result from a variety of mechanisms. There are different types of cerebral edema as well. There's vasogenic edema. There's astrocyte swelling. There's increased tissue osmolar load that can cause cerebral edema. And then there's also vascular dysregulation that occurs with increased cerebral blood volume. So these are all things that can lead to cerebral edema. And we'll talk specifically about some of these things as we progress. Maybe not in this particular part of the lecture, but later on down the road when we start talking about CVA, we'll learn about how these come into play. Okay, inflammation. It has a dichotomous role after cerebral ischemia or a TBI, and early exacerbation of damage by mediators can occur. So unfortunately, that inflammation that results in the release of cytokines and bradykinin and all those things that we know are associated with the inflammatory process can in fact cause further damage in neuronal tissue. But there is a secondary benefit through a link between inflammation and regeneration. So even though there's this early exacerbation and probable damage that occurs, without that damage and without that signaling in the brain of inflammation, regeneration would more than likely probably not occur as rapidly. So there is a positive to inflammation as well, which is why we call it, this dichotomous role. Autophagic or autophagic, depending on how you want to say it, neurodegeneration is observed after brain injury, and whether or not it contributes to or actually protects from neuronal death is something that we don't really know. It's under research, it's under investigation, but we really truly don't know if this process is injurious or helpful. Neurologic illness in the critically ill. So when patients come in to the ICU or the neuro ICU, depending on where you're working, if you're working at my hospital, we only have one large ICU where everybody goes. It's more of a medical ICU, I would call it. We call it the CV ICU or the cardiovascular ICU at Health Central. Hang on. I'm going to put my little schnauzer down. She's had enough, Papa. Okay, good girl. Okay, sorry about that. So, in my hospital, we only have one. But if you work in a very large hospital, if you're working at Jackson Memorial, for example, down in Miami, or if you're working in an environment where like Orlando Regional, for example, you're going to have several different ICUs, and in those particular units, you're going to have a specific, or in those particular hospitals, you're going to have a specific unit dedicated to neurologic care. So in your ICU, you might have neurologic illnesses that are caused by ischemia. So you might have somebody that, for example, has had either a thrombotic embolic stroke, or they've had a hemorrhagic stroke, or CVA, right? Trauma certainly can cause it. Unfortunately, we had a family member, my partner, had a niece die actually, I'll tell you when she died. She actually died the same night as the Pulse massacre, and she was a lesbian, and so the initial call that we got that she was in the ICU downtown and was not going to make it because of a severe brain injury. We got that call at like 3:30 in the morning. My initial response to my partner was, oh my God, she was at Pulse, she got shot. Now it turned out that wasn't the case. It turned out that actually she had been in a horrific car accident, which so sad. This guy was being chased by police. He had stolen a car. Car was full of drugs, and he ended up flipping the car that he stole, and it landed on top of her and crushed her. And just a terrible, terrible situation. She was a wonderful young woman, very sweet. She was, I think, 19. She was a UCF student. Her plan was to go into pediatric physical therapy. It was very, very heartbreaking. But she ended up in the neuro ICU downtown, and unfortunately, she only lived for about 12, I want to say about 12 hours. And then there's also neuroexcitation that can cause neurologic illness. And a great example of that we certainly know about is seizure disorder, right? We know that seizure can be brought on by lots of precipitating events, and that over neuroexcitation can result in neurologic damage. Consequences: initially, you get decreased cerebral perfusion pressure, or CPP, and we already talked about how we can calculate that. And it's caused by increased ICP. And eventually, you get a decrease in cerebral blood flow, which leads to neuronal loss, ultimately infarction, and of course we know that infarction equals death. So that's how that happens. There are also hyperperfusion syndromes where cerebral blood flow will inappropriately increase for a given blood pressure. And you also see in hyperperfusion syndromes vasoparalysis, and cerebral blood flow becomes linear to blood pressure. And so in other words, as blood pressure goes up, so does cerebral blood flow. And this happens because there's a loss of autoregulation, which results in this vasoparalytic event, which basically lets the cerebral blood flow go unchecked. So a very awful situation that occurs where, like we said before, you have a closed cranial vault, you increase perfusion, you increase blood volume, you're going to herniate, you're going to cause other problems. Severe hepatic encephalopathy is in the early stages can cause this. Severe head injury 2 to 3 days after, we oftentimes see these hyperperfusion syndromes. A resection of a large AVM. My partner is a family nurse practitioner in the emergency department, and he was just telling me that they had a headache come in. He works like the fast track, and he was saying that they had a headache come in the other day, and when they CT'd the headache, it was an AVM. So awful situation. After carotid endarterectomy, patients often will develop hyperperfusion syndrome, and that's because they've got this really severe stenotic lesion and they don't have any collateral. So without that collateral circulation, they end up getting this hyperperfusion. After cerebral arterial thrombolysis, often this can occur, and during administration of cerebral vasodilators at high systemic blood pressures, it certainly can cause this. So these are all other causes of hyperperfusion syndrome. So essentially you get this hyperemia, right? Increased blood flow, which results in cerebral edema or even hemorrhage if that blood flow and eventually cerebral perfusion pressure is so large that the vessel actually becomes damaged and can rupture. And then you get obviously a disruption of the blood-brain barrier, and then eventually you can also get transudation of fluid or frank bleeding. And remember that that's the thing about blood, is that blood is this hyperosmolar agent, and so your body is constantly trying to maintain this state of homeostasis. So blood will cause leakage of fluid to go with it to try to maintain that homeostasis. And so, not only do you get this gross frank bleeding, but you also can get transudative fluid accumulations that go along right with it. Temperature regulation, hyperthermia, is a deleterious effect on outcome. It's not a good thing. We definitely don't want hyperthermia. In fact, you're going to probably see in your practice the opposite. You're going to see the bear hugger. I think that's, oh no, not the bear hugger. It's called the Arctic freeze, where you'll use like cooling blankets and things to promote hypothermia rather than hyperthermia. And we'll talk more about that. But if you don't control temperature and the patient does develop severe fever, ischemia, head trauma, seizure, other things can cause this, and obviously the patient's not going to do well. Normothermia is protective with traumatic brain injury, and then here it's on this slide actually. Like I mentioned before, hypothermia is something that you're going to see used quite a bit, and we used to use this in the ICU down at Dr. Phillips when I was down there doing my residency in my acute care MP program. I saw the Arctic Sun is what the name of the blanket that we use there, and you cool the patient down to 32 to 36 degrees Celsius, and you get reduced cerebral metabolic rate. You get decreased free radical production. So theoretically, well, not theoretically, but when you decrease free radical production, you reduce the cellular death, right? Because radicals obviously end up causing cellular lysis, and reduction in neurotransmitter neurotoxicity as well. So hypothermia can have a very beneficial effect. It is something that we do a lot in the ICU in terms of brain injury, getting patients hypothermic to protect the brain. Cerebral gas exchange, cerebral PaO2, if it decreases, you end up getting vasodilation to maintain the flow through the brain, so it's a compensatory response that occurs. Changes in PaCO2, cerebral blood flow varies linearly between about 20 and 60 millimeters of mercury. Decreases in the CO2 will result in decreased ICP and vice versa. So one of the things that we used to do, now we know that it's pretty much a last ditch effort, or it's not done at all, is clinically induced hyperventilation on the vent. So you put the patient on a hyperventilatory setting with the hope that you're blowing off CO2, and you're therefore promoting vasoconstriction, which really does not occur. We don't really have any research that shows that's beneficial. Increased ICP will result in cerebral oligemia, and decreasing PaCO2 reduces ICP, but it does, of course, expense cerebral blood flow because, like I mentioned before, the overall effect is going to be vasoconstriction. So it's almost like you're reducing the ICP, but you're also reducing, vital blood flow and oxygen delivery to the neuronal tissue. Routine hyperventilation, like we said, really it's not done too much anymore. It's a last-ditch effort, and there's actually some data that shows it can actually worsen outcomes. Cerebral blood flow in injured tissue is still very unpredictable. So unfortunately, even though we know some of the things that are associated with it, it is very unpredictable. Hyperglycemia, I mentioned this before, right? So head trauma and cerebral ischemia can exacerbate glycemic control and cause problems, and you really want to use 180 milligrams of per deciliter. I don't know why it says percent, but you possibly, and we'll talk about that in a second, but basically 180 is your magic number in terms of management of glycemia in these types of patients, because if the patient becomes severely hyperglycemic, you really can end up with problems. The reason why we say possibly is because there's other research that shows that if you too tightly control glucose in the ICU environment, sometimes you can have hypoglycemic events, which we believe might even be more problematic than if you were just going to keep the patient at a higher sugar. But certainly with brain tissue being so sensitive to sugar, it is, 180 is kind of your gold standard there. But of course, it also depends on collateral flow, which is worsened with buildup of organic acids in the cells that occur from brain death. So again, the jury's out, but I would remember 180 milligrams per deciliter as your major threshold. Neuroinflammation and sepsis, you get a decreased cerebral blood flow, altered cerebral metabolic rate. It either can go up or down. You can get mitochondrial dysfunction as a consequence of this. Metabolomic, which is basically metabolites, and proteomic disturbances. So you get basically disruption of metabolic processes and a disruption of protein metabolism and protein integrity during sepsis as well. And of course, all these things can disrupt the blood-brain barrier. Encephalopathy with associated cognitive impairment is often a unfortunate outcome of sepsis. And of course, we know that decreases in blood pressure will lead to decreased cerebral perfusion pressure, which leads to oligemia and then ultimately infarction. So sepsis can cause brain death as well by causing that toxic hypotension that kills cerebral flow. Hypernatremia, also something that happens a lot in brain injury, but I'll tell you, sometimes in cerebral edema cases, and actually in some other brain injuries as well, we will clinically induce hypernatremia. And the reason why is because that sodium can actually, if you increase the sodium in the blood, and think about what I said earlier, right? Osmolarity principles, if we're delivering a hypertonic solution, what's going to happen to the cells? Are they going to gain fluid? No, they're going to lose fluid. So theoretically, what we think is if we induce hypernatremia in a brain injured patient, the cells will lose the fluid that they're accumulating from their edema and reduce overall intracranial pressure and decrease the likelihood of cellular death. Now, obviously, you would want to do this very slow. You'd want to monitor labs very carefully. Of course, you know that when you get a lab back, it's going to be hypernatremia, so you would expect that. Other causes when this is not therapeutic would be non-ketotic diabetic coma, dehydration, giving those hypertonic fluids, diabetes insipidus, panhypopituitarism, and then you'll see things clinically like thirst, irritability, seizure, intracranial hemorrhage, coma, and the rate of increase is important in the clinical presentation. So like I mentioned before, if you are therapeutically doing this, you want to increase that sodium level slowly. You don't want to do it rapidly, okay? And remember that when you deliver a hypertonic solution too rapidly in the brain, it does in fact cause brain death, and so you don't want to do that. And yeah, okay. Catecholamines infusions have little effect on cerebral blood flow or and CMR if there's no disruption in the blood-brain barrier. Studies on catecholamine use pretty much, or the role of catecholamines I should say, not use but the role, has been done in subarachnoid hemorrhage. And you see an increase in serum catecholamine levels with this, and you get a same peak incidence of vasospasm as well. And the hypothesis is basically that this injury to the hypothalamus results in this burst of catecholamines. And we think that that catecholamine release may then go on to cause that vasogenic spasm, that post-subarachnoid hemorrhage spasm and stroke that can be the cause of death after an SAH. So endogenous and exogenous catecholamines can be deleterious with comprised cerebral perfusion, like I mentioned before. So how do we treat this? You give them beta and alpha blockers. Those have been associated with improved neurologic outcomes, and sometimes you have to monitor the EEG and make sure that that they're not having any abnormal electroencephalogram activity that might indicate disorder. Okay, and that brings us to unarousable, unresponsive coma. So, consciousness, it's important to know that when a patient is unconscious, when we think of them, oh my gosh, she's unconscious, really it's not so much that they're not there, if you will, but really what it is a problem with awareness. So, in other words, the areas of the brain that are responsible for awareness of the self, awareness of the environment, arousal, okay, those are the areas that are really damaged in coma states where patients have this loss of consciousness. It requires interdependent and intact physiologic and anatomic components. So, like I mentioned, arousal and underlying neural substrates like the ascending RAS, the diencephalon, which is I want to say the diencephalon is the thalamus and the hypothalamus. Most disorders, like I said before, they really are truly impairments in arousal. So when someone has a loss of consciousness, really it's this loss of arousal that I'm talking about here. Yes, the diencephalon, like I said, is the thalamus and the hypothalamus. Okay, and awareness is, of course, a function of the cerebral cortex. And so when we have changes in levels of consciousness, oftentimes it's the cerebral cortex that's being affected. For arousal, alterations that are transient, like seizures, syncope, and cardiac dysrhythmia, can certainly be a transient cause of disruption in arousal. And then, if it's sustained, it's going to last hours or even longer. Disturbed arousal, the alert is normal, but they have other problems like stupor, which is this transiently restored wakefulness with a strong external stimuli, and at least a limited degree, I should say, of cognitive activity with stupor as well. With coma, you get an uninterrupted loss of capacity for arousal. Eyes closed, sleep-wake cycles are disturbed, and you get this vigorous stimulation that only elicits, a little bit of a response. So, you don't get a whole lot of. In some patients, you do a vigorous stimulation, you don't get any response. And then lethargy, a range of behavior that's between this arousal state and stupor. Okay, so we call that lethargic. The patient's lethargic or they have lethargy. All right. Okay, the ANP and the patho behind this. So we talked about the ascending RAS in the brainstem and adjacent thalamus. And by the way, that's reticular activating system, the RAS. And we said that the functioning cerebral cortex of both hemispheres does play an important role in consciousness. Again, with this, oh gosh, my Jack Russell's now barking at me. Okay, so the ascending reticular activating system does have some neurotransmitters involved, which include things like cholinergics, monoaminergics, GABA, and which are Y-aminobutyric acid systems, and structural or metabolic disturbances can alter arousability as well, right? And certainly we can think of very easy examples. For example, your patient that comes in that's in liver failure that has a significantly elevated ammonia level would be a metabolic disturbance, or someone that's extremely hypoglycemic, right? They come in, they have a sugar of 10. Those people are definitely going to have changes in their level of consciousness. This is the reticular activation system that I was talking about, the RAS. And you can see the cranial nerves that are involved here. It would make sense that the cranial nerves the cranial nerves involved would be the ones that are associated with sensory things, right? Like sight. So cranial nerve number 2, right, which is the optic nerve, and then cranial nerve number 8, which is the, hopefully you remember, acoustic nerve, right? So special sensory input along those nerve tracks basically is then fed to the cerebral cortex, which overall activates this system and causes arousal, okay? And then this works on a control loop system, like almost all homeostatic processes do, and this is, you can follow these same things here. This is a very easy way of looking at it, and this actually shows you where the specific brain tissue is that these sensory pathways affect. All right, so all in all, this is the reticular activation syndrome, or the system, and that's involved in our arousal, and any kind of pathophys that occurs of this particular system is going to impair arousal. Altered awareness is a disruption of cortical activity by diffuse physiology, or pathophysiology, I should say, focal lesions of the cerebrum. These can cause things like aphasia, alexia, amnesia, and hemianopsia. And remember, obviously, aphasia, they can't speak, they can't articulate words, and that can be either Broca's aphasia, where they have difficulty executing speech, or Wernicke's aphasia, where they just can't understand spoken language. Alexia, if you're not familiar with what that term is, it's inability to read. So they actually could read in the past, but now they can't recognize words when you put it in front of them on a piece of paper. And then hemianopsia is that loss of one visual field, or half of a visual field, I should say. It may not be one eye, but it might be the top of the visual field, the bottom of the visual field, the right or the left. Diffuse bilateral damage, sparing the reticular activating system in diencephalon, they get this wakeful unawareness. And so that's a little bit of a different process, but it's we'll talk more about that. I think I've got a little bit about locked-in syndrome that's similar to that as well. Not the same, but it's similar. Two kinds of altered consciousness do exist. You have altered arousal due to dysfunction of the reticular activating system with the diencephalon, or you have altered awareness due to bilateral diffuse cerebral hemisphere dysfunction. All right, so there's this dysfunction that occurs that doesn't allow the cerebral hemispheres to correctly communicate with one another. And with severe global acute reductions in consciousness, there are 4 major mechanisms pathophysiologically that leads to this. 1, diffuse or extensive multifocal bilateral dysfunction of the cerebral cortex. So the cortical gray matter is diffusely and acutely depressed or even destroyed. Concurrently, cortical subcortical physiologic feedback excitatory loops are impaired, and brainstem autonomic mechanisms become temporarily profoundly inhibited, and you get this shock below the level of the lesion. So you hear someone get in a state of psychological shock, or that's basically what's happening here. Okay, they've lost that brainstem autonomic mechanism, so they get this temporarily profound change in consciousness. So structural lesions, the location, supratentorial, infratentorial, we'll talk about that. Compression of the reticular activating system, second to swelling and displacement. Factors that are going to play a role here is going to be the rate of development of the lesion, where the location of the lesion is, and then ultimately the size too. That is going to play a big role. Cerebral mass lesion effect, you get altered CSF circulation and brain blood supply. You get an increased bulk of injured tissue and reduction in intracranial compliance, herniation syndromes, and if it's a recent lesion, then this can disturb cerebral vascular autoregulation. So you get this, like we said just a few minutes ago, this basically blasting of the vessel where it just dilates, and then unfortunately that does two things. It increases ICP, and it then compromises blood flow to the injured region. And you can get this hyperemic type hyperperfusion syndrome where you actually end up getting brain tissue death as a consequence. Not a good thing. Okay, two, direct damage to the paramedian upper brainstem and posterior inferior diencephalic ascending arousal system, which blocks normal cortical activation. So that would obviously disrupt the system of the RAS and the basically disrupt the reaching of the signals from the diencephalon to the cerebral cortex. Widespread disconnection between the cortex and the subcortical activating mechanisms acts to produce effects similar to both conditions 1 and 2. And then 4, diffuse disorders, usually metabolic in origin, concurrently affect both the cortical and subcortical arousal mechanisms, although to a different degree depending on the cause. Okay, brain herniation. We've talked about brain herniation a lot already, so we'll just kind of skip over it here because we talked about it a lot in the trauma lecture. But the rate of evolution of the mass dictates whether anatomic distortion precedes or parallels patients' deteriorations of wakefulness. And there have been cases in my career where patients have come into the emergency department and they'd have this altered level of consciousness, or they would seize, or they'd have something else going on, and we'd do a CAT scan, and they had this large tumor that was causing tonsillar herniation or other problems, is increased ICP and all those other issues that we're talking about here. So herniation, if it's transtentorial, it can actually be either central or unilateral, okay? And this is an example of transtentorial herniation. You get that midline shift, and then there are things like uncal herniation, which causes this downward compression of the brainstem and ultimately crushing of the brainstem through the foramen magnum here. There's also central herniation that can occur, and here are your clinical signs here as well. Okay, and you can read, depending on where the lesion is located and what type of herniation it's causing, you can see here what the neurologic effects of that are. All right. Okay, and then of course, one of the things I'll never forget, I may have told you this story before, but when I did my graduate degree, my first nurse practitioner program as an adult nurse practitioner, I had to go spend 2 weeks, I think it was, at the coroner's office, which was not an enjoyable experience. Someday I can tell you horror stories about some of the things that I saw in that experience. It was not enjoyable whatsoever. But one of the things I remember dissecting the brain is what you're seeing here. We would open the brain, and the really kind of cool thing is the pathologist would show me where all of the 12 cranial nerves basically dissected within the brainstem. And you could actually see these little nerve roots for all 12 cranial nerves. And it was pretty cool. You learn the 12 cranial nerves, to touch and feel, very good velvet awe was how I used to always remember it, although there's a dirty version which I don't want to share with you. When we're at a football game and we're drinking a beer, I'll share it with you and we can get a good laugh. But nonetheless, we learn these things in school and we know what they are in terms of assessment. At least we better know what they are for assessment. But when you actually see them in the flesh, literally, it really creates a different perspective. And so here you can see the reason why this is important and where this plays a role in herniation is as the brain herniates, right? So as you get, for example, let's take for example uncal herniation, right? And the brain basically herniates downward. So here's the foramen magnum. So the brain is herniating downward. What happens is all of these nerve roots here that you see, starting with cranial nerve number 6 all the way through cranial nerve number 12, become compressed. So you can expect that in patients who are herniating in the brainstem here, you're going to get disorder on your physical exam of these cranial nerves. Okay, so that's why that's important when we're looking at neurostatus and herniation. The upper motor neuron pathways are what you're seeing here, the pyramidal tracts. These particular pathways are involved in motor function. So if a patient gets damage in these areas of the brain tissue, okay, then what you oftentimes see is partial paralysis of muscles, weakness in muscles, all those types of problems that occur in motor function. Okay, so the upper motor neuron pathway or the pyramidal tracts are all responsible for that. Infratentorial lesions, displacement, compression, or direct destruction of the pontomesencephalic tegmental or cholinergic activating system can occur with these types of lesions as well. The medulla is pushed downward onto the foramen magnum, resulting in cardiorespiratory collapse. So brainstem lesions, these are abrupt lesions that can cause acute intrinsic lesions of the brainstems, which can cause an abrupt coma, which can either be hemorrhagic or ischemic. There's basilar artery occlusion, which is responsible for, would obviously be a brainstem lesion, basilar artery migraine that can occur, and then central pontine myelinosis can also occur. And so you get this demyelinating process of the central pontine region that is in the brainstem that would be very significant as well. Obviously, our vital centers are located in the brainstem, so lesions that affect the brainstem either directly, such as these abrupt lesions, or indirectly, from, for example, the medulla being pushed downward into the foramen magnum is going to cause the vital centers to collapse. So that's why this is so significant. You get a more slower process rather than these abrupt lesions we just talked about. You see a more slower process occur in things like tumors, abscesses, granulomas, and then the demyelination that you might see in, for example, MS, right? Patients that get MS, they demyelinate, and over time they can get these brainstem abnormalities and brainstem lesions as well as a result of that demyelination. Posterior fossa lesions can cause an upward herniation, and also you can get an extraaxial type of lesion which occurs outside the meninges. All right, so these are all types of infratentorial lesions that can be unbelievably life-threatening. Okay, metabolic or toxic causes of a coma include things like what am I trying to say? What is that? Ethylene glycol toxicity, different types of poisons, heavy metals, these types of things. The onset, if it's abrupt, for an example, a toxic ingestion, usually they'll develop things like general anesthesia and even cardiac arrest. And if it's a slow introduction of the toxin, then they get this period of confusion or inattention that can precede the more serious neurologic events to come. Chief manifestations of metabolic encephalopathy: arousal and cognitive function decline, disruption in the sleep-wake cycle, autonomic disturbances, and abnormal breathing variations, right? And you hear, of course, we know that breathing variation is associated with that Cushing's triad that we know is associated with, I'm sorry, is it Beck's? No, Cushing's triad. That's right. Beck's is the heart. Yeah, Cushing's triad, which you typically see with this increased ICP. So again, abnormal breathing variation, sign of serious brain disorder, obviously. Distinguishing clinical features of diffuse encephalopathy: you can get a decreased level of arousal and widespread cognitive decline, and you can get a preservation of the pupillary light response, which, remember, when you assess that, you're assessing cranial nerves 3 and 4, and then ultimately 6 when you ask for extraocular muscle movements in the patients as well. Exceptions of this: so you won't see preservation of the pupillary light response in people who overdose on anticholinergic agents. Tricyclics would be a great example of that. Near fatal anoxia, and self-initiated malingering, right? So if they're, you know, I don't know why that is, actually. I would think it would actually continue to be there if you're malingering. That doesn't make any sense. I'll have to look into that a little bit more. And then lack of pupillary reactivity, you want to search for an underlying structural lesion, right? We know that's not normal. If the patient has, I'll never forget, I had a patient one time that came in with a severe intracranial hemorrhage in the ED, and her pupils were completely blown, and she was unresponsive. She was breathing, her vitals were good, but I remember getting her into the CT room, and her eyes, I mean, it was awful. Like, I can only imagine the terror that was in this woman's brain, knowing what was going on, that she couldn't talk, she couldn't move. She was having this brain blowout, and we had to get her into surgery immediately. Metabolic encephalopathy: a deep coma without brainstem or hemispheric dysfunction of no known cause. We can assume that they suffered either an accidental or even an intentional poisoning. Diagnostically, in those cases, you can sometimes pick up those things getting a heavy metal assay in your labs. That'll pick up things like arsenic. I'm trying to think of other things that might be heavy metal poisons. Cyanide, no, I guess not cyanide, I don't know. Arsenic is the one that comes to mind. Elderly particularly are affected, serious illnesses, and certainly this will complicate surgery, and even a complicated surgery in and of itself can cause metabolic encephalopathy as well. So the longer the patient is under anesthesia, the longer the patient is remaining on the vent, all those things can result in metabolic encephalopathies. Multi-level CNS dysfunction does occur with metabolic encephalopathy. You can even get fluctuation between exams, so the patient might be a GCS score of 12 at one assessment and be a 14 the next, and then the next one they're all the way down to a 10, whatever. I mean, there's a lot of fluctuation that can occur with metabolic issues. Cognition: you usually see arousal abnormalities with these folks, so you might do a sternal chest rub, you might do pinching of the toes or something, or the nail beds, and the patient doesn't respond. Misperception, disorientation, hallucinations, concentration and memory deficits, and occasionally hypervigilance and a profound stupor and coma can occur with this. Motor abnormalities are typically symmetric and bilateral. Tremors, asterixis, and multifocal myoclonus can also occur with metabolic encephalopathy. The motor disorders you're going to see with this, they can either be hypo or hyper. So hypo might be a sedating drug or an endogenous metabolic process that would cause this. If they have a hypermotor response, it could be things from like drug withdrawal, overdose of stimulants like cocaine or angel dust or PCP. If you've ever treated a patient who has been high on PCP, it is a disaster. I've only treated a patient once in my career, maybe twice actually, but the one that I'm thinking of, this guy was built like a brick shit house. I mean, the guy was huge, muscle guy, and that is not a good combination because angel dust makes you unbelievably violent. And I remember the guy just ripping the emergency department in shreds in the room we had him in, and breaking restraints. Security couldn't keep the guy down. It was crazy. Seizures, of course, can also be a motor dysfunction of metabolic encephalopathy. So we see that in alcohol withdrawal, certain withdrawals of drugs, and in established cortical patho processes as well. Focal seizures can be related to things like hypoglycemia, hepatic encephalopathy, uremia, abnormal calcium levels, and ingestion of toxins. Autonomic dysfunction that we see associated with this, hypothermia. You'll see hypothermic responses in hypoglycemic events, cases of myxedema where you get that severe hypothyroid, and then sedative drug overdoses as well. The opposite, hyperthemia, hyperthermia, I should say. You'll see this in withdrawal states. They'll get delirium tremens. So, for example, when the patient is withdrawing from alcohol and they're getting DTs, they'll oftentimes throw a really high fever. Anticholinergic drug overdoses will cause this. So, a patient overdoses on, for example, Benadryl, or they overdose on, like I said before, tricyclics. Infection, neuroleptic malignant syndrome, which we've talked about in prior courses before, and malignant hyperthermia, all things that can cause hyperthermia in the metabolic encephalopathic patient. And we know that malignant hyperthermia, hopefully you remember from critical care pharmacology, is managed with what drug? Hopefully you remember dantrolene, right? That's the drug we use to manage malignant hyperthermia. Okay, and so we talked about some of the causes. If you want to pause the slide or look in the actual handout of the PowerPoint, you can zoom in on this. But this is just a slide that lists all the myriad of etiologies of coma. Okay, the metabolic need of the brain. Let's talk about that. So oxidation of glucose results in separation of CO2 and water. Fatty acids and ketone bodies also in emergencies, but cannot supply all. So if the patient has really severe drop in glucose or even a high hyperglycemia where they're getting ketone production. All these things are temporary fixes that really can't do much for us anyway. So cerebral blood flow is equal to about 55 cc's per 100 gram of tissue per minute. And 16 to 20 mLs per 100 grams is going to be that threshold where cerebral blood flow is just not going to be adequate. So once the patient drops to about 16 in terms of their CBF, they're going to lose consciousness. Complete cessation of cerebral blood flow, you get a loss of consciousness in about 8 seconds. The EEG will show suppression in as little as 0 to 12 seconds. You get ATP exhaustion and ionic pump failure in about 2 minutes. Selective neuronal damage can occur in about 5 minutes. Severe neuronal damage in 20 to 30 minutes. And then brain necrosis and infarction in as little as 1 hour, up to 2 hours, right? So we know that time is tissue, and brain death starts to occur pretty much within 5 minutes, right? So whatever the cause is that the patient's presenting with in terms of decreased cerebral blood flow, we got to correct it pretty fast. Hypoglycemia, glucose we know of course crosses the blood-brain barrier, and it does this through a facilitated transport mechanism. The brain uses about 55 milligrams of glucose for every 100 grams of tissue per minute. So when the sugar falls below 40, the patient gets this metabolic encephalopathy with dysfunction of the cortex before the brainstem. There are stores of about 2 grams of glucose and glycogen, and hypoglycemic coma, therefore, in these people, they can actually survive up to about 90 minutes with irreversible brain damage. Okay, unfortunately, I've seen this before. I've seen it where patients get this, what I call glucose shock, where they come in with a sugar. I think the patient I treated ultimately died of this, which, my God, when we get to the ethics lecture, I'm sure I'll end up bringing this story up and I'll tell you the whole situation, because it was a crazy situation psychosocially for us to deal with in the ICU. But nonetheless, this hypoglycemic coma, they can survive for an hour and a half, in that severely hypoglycemic state, but they're going to have irreversible brain damage as a result. Brain damage not solely by glucose starvation, but also that starvation can cause the production of neurotoxins and necrotic neurons in the white matter and the CSF pathways, synthesis of amino acids like GABA, glutamate, glutamine, alanine, acetylcholine are all suppressed, and we don't really know the sorry, you're hearing my little Jack Russell at my feet here yawning, but the pathophysiology of this is not very well understood, but it happens, and patients die from this, and it's very serious. The vegetative state. This is wakefulness without awareness. So this is your patient that has diffuse brain insults, which are various, and it can be transient where they're in this vegetative state, or we probably have all seen patients that end up in a permanent vegetative state as well. And that's a horrible situation when patients end up in that. We categorize it as being a persistent vegetative state when they reach 1 month, and then it's permanent at 3 months if it's from a non-traumatic injury. But if it's a traumatic injury, we let them go all the way up to 12 months before we label this a permanent vegetative state. The EEG is never isoelectric. You get various patterns of rhythm and amplitude. It's inconsistent, and the normal sleep and wake patterns that would be present on an EEG are absent in your patient in vegetative state. Okay, locked-in syndrome, like I had mentioned before, this is awful. This would be an absolute nightmare. These patients retain both arousability and self-awareness, but they get extensive bilateral paralysis and deafferentation. And basically remember that the afferent pathways, right, of the neuron, the afferent neuron carries impulses away, right? So if we deafferenate the neuron, they can no longer communicate with one another. So you get this horrific situation where the patient has this quadriplegia, they get this horizontal gaze palsy and lower cranial nerve palsies. They can get vertical eye movements with blinking, abnormal sleep patterns, and unfortunately, this is a permanent, horrific state, neurologic state that they can't get out of. Oh, bless you, my little Jack Russell just sneezed. Okay, abnormal sleep patterns we talked about. Common etiology of this is going to be your pontine infarctions due to basilar artery thrombosis. There are other causes that are similar to this infarction of the pontine, like hemorrhage here, myelinolysis, I mispronounced that before, forgive me, and brainstem mass lesions. Neuromuscular causes are going to be things like severe acute inflammatory, demyelinating, polyradiculoneuropathies, myasthenia gravis, botulism. Somebody just died not that long ago of botulism. It made national news. It was I think it was a man that went into it wasn't a 7-Eleven, so don't sue me, 7-Eleven, but it was something like that. It was a convenience store, and he went in and got nachos, and the cheese sauce that he poured all over the nachos came out of a can that was infected with botulism, and he ended up dying. Very, very sad. And then neuromuscular blocking agents can also cause this. And you get this upward gaze is not selectively spared, and so this horizontal palsy of gaze is what you typically see with this locked-in syndrome. It's basically like the patient's locked in their body and they really can't move. It's just terrible. I've never seen it, but I've certainly read about it, and I worked with a doctor of physical therapy, a really great physical therapist at Health Central, who he ended up leaving Health Central and got a job with HCA. I've remained friends with him, although he's ended up having a family, and it's difficult now with kids and everything. But he was one of the most brilliant physical therapists I had ever worked with, and he had done an additional residency in physical therapy in the intensive care unit, and so he was very smart with managing physical therapy related approaches, if you will, in the ICU. And I remember he had told me he treated a patient once that had locked-in syndrome, and he was saying, "Oh my God, if I ever got that, I would really hope that one of my family members would give me the pillow treatment." Akinetic mutism is a rare subacute or chronic state of altered behavior. So what happens is you get this alert appearing patient, but the patient is silent and immobile, but they're not paralyzed. And there's usually this external evidence of mental activity that's unobtainable. So you can't really assess this. Lies with eyes opened and they retain a cycle of self-sustained arousal. Skeletal muscle tone can be normal to hypertonic but not spastic. They're doubly incontinent. Yay, fun. They're again, this is very similar to what we talked about before, where they get these variable lesions. So it's kind of like a vegetative state where they get these severe lesions that occur, in multiple locations, and they get this process. Catatonia symptoms are complex, and usually we see this with psychiatric disease. The behavior can be things like stupor or excitement with variable mutism, posturing. What was that? Waxy flexibility. That's what it's called. When you can go up to a patient that's got catatonia and, like, for example, lift their arm above their head, and then they'll keep it there, right? That's called waxy flexibility. Rigidity, grimacing, and catalepsy. And again, like we said, the causes of this are typically psychiatric, but you can also see this in structural disorders and metabolic problems as well. Okay, and if you're not familiar with catalepsy, that's basically a trance, and they get this loss of sensation and consciousness accompanied by this rigid body. Okay, they do not move spontaneously and they appear unresponsive to the environment despite normal levels of arousal and consciousness. They usually lie with their eyes open, but they may not blink to visual threats. Pupils are semi-dilated and reactive to light. Oculocephalic reflexes are absent, and the vestibulo-ocular testing evokes a normal nystagmus response. And also they can hypersalivate, and like we mentioned before, in our mutism patients, they are doubly incontinent. So they're the patients that nurses love to take care of. So approach to coma, not coma, but coma. Acute life-threatening emergencies are what result in coma. So we definitely have to employ the right approach in the emergency room by getting a very good, thorough history, finding out what exactly is involved in the patient's presentation, doing a very good physical examination, which of course is going to be include a comprehensive neurologic examination, neuroprofiling, and then specific management depending on the diagnosis that we ultimately derive at. So ER management, oxygenation obviously is always going to be first. Airway, breathing, circulation. So these patients do have a low threshold for intubation, and in other words, patients that come in with neuro issues, they are going to be likely candidates for intubation. A brief neuro exam is of course going to be mandatory if we're going to use sedation. Obviously when we intubate, we sedate, and if the patient's sedated, this is going to mask neurologic symptoms. And we can talk actually a little bit more about that. It's not going to be in this unit, I think, but in the next one or the one after that, we're going to talk about how in the ICU we can actually use an EEG to kind of override sedation and see what's going on in the brain despite sedation. But obviously, in your physical exam, the patient's sedated, you're going to miss things. You want to do a rapid neuro exam from about 3 to 5 minutes. You can do a hand drop from the head to assess for malingering, or if this is a psychiatric event. Obviously, if you do that and their hand smacks into their face, they're not malingering. If they do drop the arm and it avoids the face, then more than likely this is psychiatric and they're malingering. Pupillary size and reactivity, looking for abnormal eye movements, asking again, what are you assessing there? You're assessing cranial nerves 3, 4, and 6. So you want to ask the patient to look in your light going from the sides, follow through the cardinal eye gazes. Grimacing and withdrawal from noxious stimulation, that's a good finding. We want that. An abnormal plantar response like a Babinski, is it unilateral or bilateral? And then looking at respiration and ventilation, making sure we're monitoring the SpO2, we are obtaining our ABGs, keeping the PaO2 greater than 100 and the PaCO2 between 34 and 37 is going to be ideal. Avoiding hyperventilation unless they are actively herniating. Avoiding PEEP. Oof, gosh, think about that, guys. What does PEEP do? PEEP increases intrathoracic pressure, increases in intrathoracic pressure. Geez, that's difficult to say. Will increase ICP. So we want to avoid excessive PEEP. So in these patients, you want to keep the PEEP around 5. You wouldn't want to go above that. NG tube to facilitate gastric lavage and prevent regurgitation would be important as well. Assure cerebral perfusion in these folks. How are we going to do that? We're going to maintain an adequate blood pressure. We're going to use lactated ringers or normal saline. Remember that we've learned that lactated ringers is oftentimes considered the ideal replacement fluid, particularly if we're going to give large boluses, because it will avoid that hyperchloremic acidosis that you can get with saline. Keeping a map of 100 is considered adequate and safe for these folks. Collecting blood for tests. Obviously, you're going to want to get a metabolic panel. You're going to want to get a CBC with differential. You're going to want to get a tox panel, an alcohol level, a UA, all these things very, very important. Replace blood volume quickly if that's the cause of the presentation, and we already learned in the first unit of the course that using vasoactive agents is also sometimes warranted in these folks, and we shouldn't be scared to use them because we have research that shows positive outcomes with their use. Manage systemic hypertension with hypotensive agents that do not raise the ICP through vasodilation. So examples might be labetalol, hydralazine, and nitroprusside. Remember though that nitroprusside can release cyanide and cause cyanide toxicity, so that's something that we have to administer very cautiously. Don't treat systolic pressure unless it's greater than 160, and we want to make sure our urinary output is at 0.5 mLs per kg per hour, and that they are full lead, although I will tell you that there's some controversy with that because Foley catheters have been associated with rises in ICP, and but then again, what are you going to do? Let the patient urinate all over themselves, and we need to be measuring urinary output, so they're going to have a Foley. Okay, and this is emergent evaluation and management of stupor and coma in adults. Pretty much everything that I mentioned before. Obviously, when it comes to imaging, you're going to definitely want to get a CT scan. Obviously, if you're going to do a lumbar puncture, this is going to be if you suspect a brain bleed, or you suspect an infectious process. And remember that if the patient has increased ICP, you would never, ever, ever want to do a lumbar puncture because you'll kill them. They'll herniate immediately. And so what can you look for to rule out increased ICP? Remember papilledema. So you can do a retinal exam and actually rule out papilledema in these folks. Okay, so EEG, you wouldn't really do that in the ED, but certainly in the ICU we would do that. A head CT scan without contrast would definitely be warranted. Getting an EKG would be important, maybe even a chest x-ray to make sure that the cardiac function is okay, to make sure there's not an infectious process like pneumonia or something else that could be causing the problem. And notice your ABCs here, that you're going to intubate if the GCS is less than 8. You've heard me say that before. If the GCS is less than 8, intubate. Stabilizing of the C-spine, giving supplemental O2, getting IV access, and then supporting blood pressure. All these things are going to be very, very important. All right, so you can look at the rest of that on your own, but again, this is a really good table that Dr. Reichman took from Up to Date that I decided to keep in the presentation. So another way that we manage coma is with glucose. 25 grams as a 50% IV solution with thiamine at 100 milligrams. Immediately after blood, we want to draw blood for labs after that. Thiamine with glucose to prevent precipitation of Wernicke's encephalopathy in malnourished and thiamine depleted patients. So alcoholics, for example. The thing that is important though is what we're saying here is actually you want to draw the blood after, or you want to give this, I should say, after your blood draw, because if you give a very hyperglycemic injection into the patient and then you draw the labs, you're going to get a possibly false elevated glucose reading. And when I mean elevated, it's not necessarily going to be hyperglycemic. It could be low, but unfortunately what you're getting is a false reading because you're getting the sugar that you just pushed into the patient versus what they presented with, and that's not going to be very helpful. Obviously, if the patient is seizing and has to be stopped, we're going to use Ativan 2 to 4 milligrams or diazepam 5 to 10 milligrams. Remember that diazepam is associated with severe necrotic problems if it extravasates into the IV site. Control with Dilantin at 18 mg per kg IV at 25 milligrams a minute. Seizure breakthrough requires additional benzos, additional Ativan. Careful and mild sedation for agitated, hyperactive patient to prevent self-injury is going to be important. Using Haldol, 1 milligram as often as hourly until the patient is sedated, and then even morphine at 2 to 4 milligrams IV. For drug overdoses, this is going to be the largest single cause of coma in the ER. I don't know if I would say most, but certainly many of them can be treated by supportive measures alone. Giving Narcan is wise if we have a strong suspicion of opiate on board. Obviously, if the patient has oh, my partner just got home and my dogs are going crazy now. Sorry about that. Obviously, if the patient is an addict and they're used to having opiate on board and you give them Narcan, it's going to put them into immediate withdrawal. And it's funny because my partner will tell me stories of patients that come into the ED and they're overdosing on heroin, for example, and he'll say, okay, we're going to give Narcan, and all of a sudden that patient who was drowsy, unresponsive, barely interacted before, all of a sudden, no, I don't want Narcan, because they know it's going to put them into withdrawal. Do not attempt to reverse completely all drug effects with that first dose. Remember that you may actually have to put them on a drip of Narcan. You may need to give them multiple doses. You can't just expect them to magically improve with one dose. Romazicon, we're going to give as an antidote for benzos. We learned this in critical care pharmacology. If they're not responsive to 5 milligrams in divided doses, given over 5 minutes, then we can safely assume it's not a benzo problem. Recurrent sedation is prevented with 1 milligram IV every 20 minutes in a patient who is snowed on benzos. So like we said before, hyperthermia, very dangerous. It increases the metabolic demand. If that temp gets greater than 104, then we're going to have to do cooling measures. Usually this is indicating infection, but not always. We learned that, for example, metabolic processes can often cause hyperthermia in neurologically impaired patients as well. You also can see this in intracranial hemorrhaging, anticholinergic drug intoxication, heat exposure. And then on the opposite end of the spectrum with these patients, you get hypothermia. And if the patient has a temp of 93.2 or less, then we're going to want to slowly increase them up to about 95 to prevent cardiac dysrhythmia. All right. This is oftentimes accompanied by profound sepsis, a sedative or hypnotic drug overdose, drowning, hypoglycemia, and Wernicke's encephalopathy. Babe, can you take them out? I think they need to go potty because Gabby's been whimpering for a little while. Okay, sorry about that. Okay, so history in the coma, that's going to be important. Was it a witnessed event? Did the patient, in fact, have a head injury? Did they seize? If there was a motor vehicle collision, what were the associated situations? Did the patient have a seatbelt on? Did the airbag deploy? Where was the mechanism of impact in the car? Was it on the driver's side, the passenger side? Was it head on? Was it a rear collision? How about evolution of the coma? Is that evolution happening abruptly or gradually? Does the patient have a headache? Or did they report a headache at any time? Progressive or recurrent weakness, vertigo, nausea, and vomiting. Recent medical history that might indicate problems with neurostatus that can lead to this, like prolonged surgical procedures or complicated surgeries where a high dose of anesthesia had to be used for an extended period of time. Infections, current medications that the patient's on, particularly like we've said, those that have strong anticholinergic properties to them. Past medical history, which includes things like epilepsy, injuries to the head, drug or alcohol abuse, stroke, hypertension, diabetes, heart disease, cancer, uremia, anything that might clue us into what could be a cause of the presentation. Obviously, if there's a psychiatric history, particularly if the patient tells you or the family member tells you they have a history of depression and suicide attempts, then those things would make us more keen on assessing a metabolic process from intoxication. And then what is their access to drugs? Do they have easy access to things like sedatives or psychotropics, narcotics, illicit drugs like heroin, right? Or PCP like we talked about, that causing neurologic disturbance. Drug paraphernalia, and then looking for empty medicine bottles. Did EMS, when they came on the scene, say that the drug cabinet was searched and the Elavil that was in there that the patient normally takes for sleep, which is a tricyclic, was gone. There were no pills in there. Your physical exam, obviously, efficacy of resuscitation measures are going to be crucial. Looking for external evidence of trauma. We already learned how to look for some of these things in the first unit on trauma. Evidence of acute or chronic medical illnesses, evidence of ingestion or self-administration of drugs, so looking for needle tracks on the antecubital fossa, smelling for alcohol on the breath, arson, oh, not arson, is it arsenic? I think arsenic, yeah. What is it that they get this almond. That's what they say it is. They get this almond smell to the breath. Evidence of nuchal rigidity. Caution is required if severe neck injury is possible or hasn't been excluded. And nuchal rigidity may actually disappear if the patient's deeply comatose. That makes sense. So they may have something like a meningeal infection or inflammation or meningitis or encephalitis and not present with that nuchal rigidity that we see, for example, when we conduct a Koenig's reflex or a Brzezinski's reflex, and so those things become unreliable in patients who are comatose. The neurologic profile, correct interpretation of neurologic signs that reflect either the integrity of the impairment or their level of function in the brain is important. So our differentials are going to include things like supratentorial or infratentorial lesions, structural lesions, disturbances in metabolites with metabolic disorder or toxic disorders that cause encephalopathy, and then psychiatric disturbance as well, all being issues that can lead to this. And then the Glasgow Coma Scale, we've learned about this since Nursing 101. Most of you probably use it in the clinical environment. It's a very valuable tool. It's clinically challenging to use it in these patients, though, I will tell you, because these patients oftentimes get such wide variability in their neurologic presentation that the GCS is not always great. But it is the most widely used. It is going to be less effective in patients who are intubated, and we don't really have a lot of info on the use of the GCS in terms of assessing brainstem function, and it doesn't really take into effect respiratory status, obviously, as well. So, all those things are very important with brain injury, and you're not going to capture that on the GCS, unfortunately. There is a modified GCS, which is pretty cool. You may be familiar with it. If you're not, you can take a look at it, because here it is here. And then the 4-score. And the 4-score is also pretty easy to look at. Usually these tests are not done in isolation. We do a bunch of these tests because we know that the validity and reliability of them used alone is not pretty good. But this is the 4-score test. I've also put a really cool schematic of the 4-score assessment on your website for the course. It's a Mayo Clinic document. I would encourage you to look at it. I don't know if I'm going to test you on it. That's not why I'm telling you to look at it, but just look at it because it explains this pretty easily in that handout. But this 4-score is a neurologic test that we do use in patients who have coma or who have severe brain-related injury. And this is an example of the 4-score of what you want them to do. Okay, so different things. And continuing on. Okay, level of consciousness assessment scales that are electronic. Again, like we mentioned before, accurate physical exam is going to be vital. There's also a level of consciousness or loss of consciousness that can be assessed through different scales, and there is the NIH stroke scale. There's an online calculator. If you click on that link there, that'll bring you to that. There's a free app that you can download for that as well, and there's an iPhone application for this through the iTunes store as well. All right, and I've always told you that I'm a big fan of the CliniCalc app that you can download to the iPhone. I'm sure you can probably get it for Android phones as well. But you see a lot of these instruments in this particular app. So for example, your Nexus criteria that we talked about for C-spine injury and imaging and all that good stuff. The NIH stroke scale is on the CliniCalc app. The Glasgow outcome scale is on here. There's just lots of different lots of different tools you can use. Even the 4-score that I just talked about is on this particular app, so you can actually perform the 4-score right through the app. You can actually look at eye response, motor response, brainstem reflexes, and respirations. Insert the data into the app, and it will then calculate what the 4-score is. So I think this is like at most $5, but it actually might be cheaper than that. It might be like $2. So it's worth it. All right, go to the iTunes store. I don't know. I have an iPhone, so I'm not sure what Android uses. The Android store, or whatever it's called, the Google store, and download CliniCalc. I think it's worth every penny. You'll thank me for it later. So altered level of consciousness, you want to use those scales, but you also want to look at your physical exam findings. We talked about neurologic examination in the first unit related to trauma, but obviously want to look for things like eye movements, which would assess cranial nerves 3, 4, and 6, brainstem reflexes, looking at autonomic responses, vital signs, respiratory rate, all those good things. Movement, is it spontaneous? Is it responsive? Looking at a fundoscopic exam. Obviously, we're not going to give any mydriatic agents. That's probably stupid to even include on the slide, but nonetheless, that's going to be important because if you're thinking of doing, for example, a lumbar puncture on a patient that you believe may have a brain hemorrhage and you want to assess for blood, or you're thinking that maybe the patient has, for example, in that case, a subarachnoid hemorrhage. Oftentimes a subarachnoid hemorrhage, they'll bleed a little bit, then the vessel will stop bleeding. But if you do a lumbar puncture, you'll have actual red cells that appear in the CSF, so you know that the patient was actively bleeding at some point. Or you might want to look at the patient with meningitis. You might suspect an infectious process. Well, if you're going to do that, guys, you do not want any risk of increased ICP. If the patient has increased ICP and you do an LP, you're going to kill them. Looking again at the breathing pattern, remember that Cushing's triad, right? Where you have that widening pulse pressure, you get that erratic respirations, and you get that bradycardia. But remember that that's only in a small percentage of patients with increased ICP. It doesn't happen with everyone, and those things are all going to be important to assess, which obviously would include your vital signs. And this is a pretty cool table. I'm not sure where Dr. Reichman got it from. She may have just made it up on her own, but it's pretty cool. You can actually see where the disorders are and what you're seeing in terms of the pathophysiology. So if the disorder is, for example, in the cerebral cortex or in the reticular activating system, which we already talked about, right? That is arousal, right? These systems are going to be arousal. Things like your sleep-wake cycle are going to be disturbed, conscious behavior are going to be disturbed. Brainstem motor pathways, obviously, that's going to be motor or muscle, so limb movements are going to be affected, right? And then if you've got a midbrain injury that involves cranial nerve number 3, the oculomotor nerve, you're going to have disruption of innervation of the extraocular muscles. If you've got a pontine lesion, this is going to be the gazing disorders that we talked about with some of the issues we've already discussed. Cranial nerve number 5 and 7, remember these are tested together. You ask the patient to clench their jaw really tightly and puff the cheeks, making sure that the muscles are symmetric. If they're not, if you have an upper pons lesion of these areas, then you're going to have problems with the facial features and the facial muscle. You might get drooping, you might get corneal reflex that's off. So if you touched, for example, a 2x2 on the eye, normally the patient would blink, right? But in this particular case, if they have a cranial nerve number 5 lesion, they're not going to do that. And then in the lower pons, these are going to be things like cranial nerve number 8, and then other pathways with 3, 4, and 6, which again are going to be your PERLA and your EOMs, so reflexive eye movements, your doll's eyes, right? So remember what doll's eyes are. Doll's eyes where so the patient starts in the midline, and if you turn their head to the left, like if you do this to yourself, right? If you look straight on and turn your head to the left, your eyes will still fixate on the center. And if you turn your head to the right, the same thing will happen. Well, if you've got doll's eyes, it's like just what it says. It's a doll's eyes. So in this particular example, when you turn the patient's head to the left, the eyes will also gaze to the left. They will not stay centered. And same thing with the right. You move the patient's head to the right, the eyes track to the right. They don't stay centered. And then ice caloric responses that occur with a lower pons injury. Basically, for these patients, they're unresponsive, they're in a coma. If you drop ice water with a dropper into the ear, what you would normally see is the eyes will actually deviate towards the ear in which you've dropped the ice water in. So if you drop it in the right ear, or AD was how you abbreviate that, then the OD, or the right eye, will gravitate or actually move towards the right ear. And if you do it on the left, same thing, okay? And then pontomedullary junctions, you get breathing disorders, like spontaneous breathing can be disrupted, and then your vital centers can also be disrupted, so BP will drop. And the spinal cord, obviously, your DTRs and your Babinskis are going to be affected. So this is a pretty cool table. I'm glad we took the time to go through it because I can see a couple of test questions coming from this table. So I would know, based on your physical exam finding, what kind of lesion or what kind of injury are you suspecting in the patient. Supratentorial mass lesions affecting the diencephalon and the brainstem. It's an initial focal cerebral dysfunction that progresses rostral to caudal, and signs are reflective of the dysfunction at one level, and it's often asymmetric. Subtentorial lesions, symptoms of the brainstem dysfunction or sudden onset of coma. Brainstem signs can precede the coma or accompany it. Cranial nerve and oculovestibular dysfunction and early onset of abnormal respiratory patterns in subtentorial lesions as well. With our metabolic toxic coma, confusion and stupor oftentimes preceding the motor signs that the patient has, which are usually symmetric. Pupillary responses are generally preserved in these cases. The patient can get myoclonus, asterixis, tremulousness, and generalized seizure. And acid-base imbalances are going to be common with these folks. Patient overdoses, for example, on aspirin. We know that that's salicylic acid, so the first initial presentation with those people is usually acidosis, but they'll eventually go on to develop alkalosis as a result of aspirin toxicity. Psychogenic, usually the eyelids are squeezed shut, so if you palpate the orbicularis ocularis muscle around the eye, it's clenched, it's tight. That's not normal in somebody that's comatose from a true neuro disorder. Pupils are reactive or dilated, or they're unreactive. Oculocephalic reflex is unpredictable, and nystagmus is what can occur on caloric testing. So you drop that ice water in and their eyes just kind of oscillate. Motor tone is normal or inconsistent, and there's no pathologic reflexes. And if you do an EEG in these people, they're going to have a normal sleep-awake pattern. Management of supratentorial lesions, determine the severity and rate of evolution, stabilize the patient, get an emergent head CT or an MRI. Remember, without contrast is the initial CT scan of choice. This can tell us the nature of the lesion and the mass effect. We can see if the patient needs to have an evacuation of an epidural or a subdural, and then if they've got an intraparenchymal mass, I don't know why I would say non-surgical approach, because some of these are going to require surgery. And then medical therapy for intracranial hypertension, obviously. Brief rapid hyperventilation, we talked about that as probably not being very helpful, but in the case of patients who are actively herniating, it might be something to try. These are parameters we've already talked about, I should say. Give osmotic agent at the same time. So mannitol is going to be your osmotic agent of choice here at 20% as a 1 gram per kilogram bolus. And one dose will last 6 hours for that as well. Okay, if steroids are indicated for severe vasogenic edema, then we give Decadron. Okay, remember that you never give Decadron in a patient who's actively bleeding. You would never ever want to do that, but you want to give it in somebody with severe vasogenic edema at a bolus of up to 100 milligrams, followed by 6 to 24 milligrams every 6 hours. This would be something I'd be consulting the critical care pharmacist about to help guide some of that management. Monitor vital signs, and you want frequent neuro exams with these folks. Elevate the head of the bed to at least 15 degrees, maybe even a little bit more. Reduce that ICP. Repeat mannitol every 4 to 6 hours on these folks, but also pay close attention to serum electrolyte and fluid balance. Remember, we talked about how, for example, some of these patients can end up developing severe hypernatremia and some other electrolyte disturbances. Ventriculostomy, if they're not responding as expected, or if they end up developing an obstructive hydrocephalus, then we're going to have to do a ventriculostomy. And they do that into the lateral ventricle, and that can help us measure ICP. So we can actually put an actual barometer there that we can assess ICP. And then this is also a good connecting site for a drain. Calculating CPP, we've already done that in the first unit of the course, and we want to drain any kind of hydrocephalus to relieve increased ICP and keep the cerebral perfusion pressure greater than 60. All right, so that's going to be our goal for that. Infratentorial lesions, evolution of clinical presentation allows for localization of the lesion to the posterior fossa. It may be intrinsic or extrinsic to the brainstem. Emergency management is going to include CT imaging, like we talked about before. Measures to decrease ICP, cerebral hemorrhage, or cerebellar hemorrhage, or infarction. They're going to need an evacuation if that's going on. Intrinsic brainstem lesions are going to be treated conservatively with osmotic agents and steroids. Surgery or radiation might be necessary in those folks as well. And then these people are going to have a more conscious placement of a ventricular catheter. It can be dangerous in upward transtentorial herniation and even fatal. So, all these patients are going to have a neurosurgeon on consult anyway, but we would defer anything like this to the person that would actually be putting that in. For our tox patient, our metabolic coma, preserve and protect the brain from permanent damage. So if they're hypoglycemic, we need to replace their sugar. If they're hyperglycemic, we have to do the opposite. We have to very slowly and carefully lower the sugar to that 180 threshold that we talked about as being important. Metabolic and toxicology studies are going to be important with that very first blood draw. Obviously, a patient presents to the emergency department. The first thing you do, if they are altered level of consciousness, you're going to be getting a bedside glucose check, right? Obviously, we're going to check their blood sugar after we check their what? Hopefully you just said oxygenation status, Dr. Blackwell. That's right. Getting their SpO2, making sure their airway is open and effective. The very next thing you want to do is check at minimum a capillary AccuCheck. Treatable conditions, like we mentioned, are things like hypoglycemia, acid-base balance disorders, hypoxia, meningitis, and drug overdoses. 50 mLs of a 50% solution of glucose IV if the patient particularly has hypoglycemia. But don't give if there's permanent damage that can occur. What we're trying to say here. Permanent damage can occur with hypoglycemia. If you give it, it may worsen hyperglycemic hyperosmolar coma. If the patient is already hyperglycemic and you're making the wrong choice here because you think it could be hypoglycemia, and it may help decrease elevated ICP and lighten non-hypoglycemic coma. So there's risks and benefits to giving that push of glucose. So keep that in mind when you're deciding whether or not that is going to be the first thing you do. Hyperventilation for acute severe metabolic acidosis, it's going to require treatment, and there's also the danger of this cardiovascular collapse with this approach as well. Drawing ABGs, obviously administering bicarb is going to be valuable in a number of very rare cases, and then obviously searching for the specific cause and treating that. What is it that's causing the metabolic acidosis, or what's causing the alkalosis? What are the things that are happening here in this metabolic state that we could correct? Hypoxia, carbon monoxide poisoning. This is probably a great time for us to talk about that. Remember, the first thing you want to do is put them on 100% O2, right? So we want to hyperoxygenate them, and that actually helps to facilitate excretion of carbon monoxide. We want to monitor and correct their blood pressure and any kind of dysrhythmia they might be having. Idiopathic and drug-induced methemoglobinemia is treated with methylene blue, 1 to 2 milligrams per kg IV, and then that's repeated in an hour if needed. And anemia exacerbates other forms of hypoxemia, but does not in and of itself cause coma. All right. So the rule of thumb there is if the hematocrit drops below 25%, you're going to want to transfuse them. Cyanide poisoning, you might see this in nitroprusside toxicity, or you might see this in burn victims. Or people who have inhalation injury that are around plastics and other materials that burn and give off cyanide gas. It is a histotoxic hypoxia of the brain. We would treat it with amyl nitrate, which is either given as a vapor or through a crushed ampule that's inhaled every minute. We can give sodium nitrate at 300 milligrams through the IV, and sodium thiosulfate 12.5 grams through the IV to correct this as well. All right, so patient comes in and they've been exposed to smoke inhalation. Again, these things are going to come into play here. Your carbon monoxide poisoning and your cyanide poisoning in these folks as well. Remembering that the effects here are beyond just the respiratory system, but actually into the neurologic system as well. For meningitis, the unconscious patient with a fever or meningeal irritation signs, again, you want to make sure you get a head CT prior to that LP, looking out for lesions, looking out for anything that might be associated with increased ICP. So increased ICP is present, but the LP is not contraindicated with diagnosis. But if you've got herniation, you would never ever want to do that in an adult, but I guess they say it's okay in children. So hyperventilation and IV mannitol might be indicated for those folks who have increased ICP. More cautious with rapidly deteriorating neuroconditions. So if they have focal signs or seizing, papilledema, like we mentioned before, is rare, but it is a good assessment to look for in patients with suspected increased ICP before you perform that LP. And then if we're going to look at the spinal fluid gram stain, initiate antibiotic treatment. If it's negative but we suspect bacterial cause, we're going to treat it with an empirical broad spectrum antibiotic. So you're going to choose a third generation cephalosporin, and then you're going to add vancomycin to that as well. Okay, so remember that vancomycin is an aminopeptide. We've already talked briefly about that, how the aminopeptides can cause permanent tinnitus, renal failure. They're renal toxic, they're ototoxic, and so that would be an example of something you'd have to look out for. And then you might use something like Ancef, cefotaxime, for example, as your third generation cephalosporin that you might select. Okay, so overdose, emergent supportive measures that we've talked about, removing, neutralizing, or reversing drug effects. Remember that recent drug ingestion can induce coma. We may have to do gastric lavage on these people. Head down position on the left, 200 to 300 cc's of tap water, or half normal saline till it's clear, and then administer 1 to 2 tablespoons of activated charcoal after we've done the lavage. I've heard lavage has really kind of fallen by the wayside for some reason, but we used to do it a lot when I was an emergency nurse. Hemodialysis, again, it could be something too that the patient might be hooked up to in these events, particularly if they've overdosed on barbiturates or glutathione, which is a non-narcotic sedative. Some other general care, tissue perfusion and oxygenation needs to be at the forefront of our consideration. Aggressively rapid treatment of infections, prevention of agitation, DVT prophylaxis. So we're going to put them on, a low molecular weight based heparin, for example, like use of Lovenox when they come into the unit. SCDs, enteral or parenteral feeding. Remember, we want to stimulate the gut. We want to get the gut, the mucosal integrity preserved. So within 48 hours, our hope is to get them on feeding. prevent corneal injury through lubricants and maybe even taping the eyelid shut. Okay, guys, that was a lot of material, but it was a lot of very important material. We covered a lot of ground there with neuromuscular and neurologic healthcare problems, particularly in the ICU, in the ED environment, how we assess these, how we correctly manage these, and we learned a lot about the pathophysiology as well. Thank you to Dr. Reichman again for providing the material for this lecture, and thank you for your attention. I appreciate it. I know this is a lot, guys. I know you're thinking to yourself, oh my God, I'm so overwhelmed with this. You can do it, okay? I have faith in you all. We've all been there, and you can do it. So thank you. Again, my name is Dr. Christopher Blackwell. I am an acute care nurse practitioner and an adult nurse practitioner. I'm the associate professor and program director for the AGACNP program in the College of Nursing within the Department of Nursing Practice at UCF. Hope you have a wonderful day. God bless, and thanks again for your attention. Bye-bye now.